We'll go to the program. Now I request our IMA TNSB Academic Committee Chairman, Dr. M.S. Ashraf sir, to give welcome address. Sir, please, sir.
Thank you. Good evening to all. It's a great pleasure on my behalf of Tamil Nadu State Academic Committee to welcome you to this very important session. I feel it is our duty to judicially use antibiotics, avoid use antibiotics wherever it's possible, and if it is really necessary, judicially use it, so that we should be aware that whatever we do now, we are passing on to the next generation, our own children, grandchildren, that they will find that the antibiotics are not working. So I think that is more important. We have a right person, Dr. Purandeswamy here, who is going to moderate this session. He is a very social person. He has done a lot of work and is a trendsetter as well as a director of public health. And Neminathan, when he requested me, he thought I am doing a favor. Now I know he is doing us a favor by propagating this message. I have great respect for Dr. Sengutuvan, Dr. Karthik Prabhu, our secretary, our president Sengutuvan, secretary Karthik Prabhu, our treasurer Gauri Shankar, past president Abdul Hassan, and the president-elect Sridhar. Without mincing words and wasting time, there are a lot of people who are joining in, and it is a very important session. Youngsters are all there. How we to use antibiotics, when not to use antibiotics, and it's going to be addressed by none other than Dr. Neminathan and moderated by Purandeswamy. Welcome you all. I respect all the delegates who are here. Best wishes to all of you. Please take part, interact, get the experts' opinion, and we'll follow that. Thank you so much. God bless all of you.
Yes, sir. Now,
may I now request Sengutuvan to say a few words, sir. Sengutuvan, sir, just say a few words.
Thank you, sir. Thank you, sir. Respected President-elect Dr. Sridhar, immediate past President Dr. Abdul Hassan, Academic Committee Chairman Dr. Ashraf, Honorary Secretary Dr. Karthik Prabhu, Finance Secretary Dr. Gauri Shankar, and today's eminent speaker Dr. Neminathan, moderator Dr. Purandeswamy, ex-Director of Public Health, and all the delegates. Good evening to everybody. Neminathan is known for his elegant subject, and he is a very good academician also. So he is running the respiratory diseases for the CGP and infectious diseases also as a coordinator. He is giving very good lecture, and his lecture will be always useful to the practitioners who are doing this is a viral period. He will give necessary advice and what are the do's and don'ts, the antibiotics. Best wishes to the team, Academic Committee team, headed by Dr. Ashraf and Arul Jodi and other members. Thank you. Thank you, sir, for your wishes. Thank you, sir.
Thank you.
Over to Arul Jodi.
Sir, next we request our Honorary Secretary Karthik Prabhu sir to give felicitation speech.
Yes, sir. Most respected President Ashraf sir, speakers of the day, good evening, everybody. Really wonderful, sir. Academic Committee is doing a wonderful job, and this is a very, very timely meeting, and especially in this particular day of impatience to use antibiotic. A very, very important topic, timely organization. I appreciate Ashraf sir and Abdul Jodi sir for this wonderful initiative. All the best, sir. Thank you.
Thank you, Karthik. Thank you. So nice of you, Karthik. Abdul Hassan. Abdul Hassan.
Sir, 1 minute, sir. He joined, sir.
Abdul sir. He joined. He is already joined.
Abdul sir.
Yeah, thank you.
Welcome, sir.
Good evening. Good evening, respected past President Dr. Ashraf, Arul Jodi, and all the members of Academic Committee, President and Secretary of IMA TNSB. It is wonderful to have this seminar on AMR week, which started on 18. It is going up to 24. And I'm very happy Tamil Nadu is in the forefront in sensitizing our people regarding antimicrobial resistance, because we all know that antimicrobial resistance is a silent sabotager, which is going to be a big sabotage in the years, maybe in 1 or 2 decades time. Already it started happening. So it is the right time that we all united together, and IMA headquarters, AMR committee, and our Hospital Board of India also is having program. Tomorrow hand hygiene at 12 o'clock. I will send you the link. You can all join and join, put your video on and do a hand washing in front of the camera so that it will be taken photograph and will be sent to WHO. That is a program by the AMR committee of IMA headquarters and Hospital Board of India. So in this juncture, I am very happy that we are also doing it here in a different way in Tamil Nadu, and congratulate Dr. Ashraf sir and Arul Jodhi and President Secretary of IMA TNSB for taking up this very, very important and patriotic work. Thank you very much for the opportunity. Over to you, Dr. Ashraf sir.
Thank you, Operation. Thank you, Operation. Is Gauri Shankar there online? Gauri?
No, no, sir, not available.
Sridhar is not there, then we'll proceed with the session. Please introduce the
Yes.
speakers and the moderator. Let us
Sir,
have a useful discussion.
Yes, sir. 1 minute, sir. Now, I request Dr. Neminathan, sir, to introduce our moderator, sir.
Thank you, sir. Dr. Kulandeswamy, sir, the former Director of Public Health, needs no introduction to all the doctors in Tamil Nadu. He is a very well-known figure in Tamil Nadu. He is, in fact, a role model for many of us like me. Sir started his career as a PHC medical officer in a remote village in Kotagiri, and then he ascended to the top of the ladder to become the Director of Public Health. He is one of the pioneers in reducing the maternity mortality rate and infant mortality rate in Tamil Nadu. He has presented lots of papers and received lots of awards, including the Best Doctor Award from IMA and TNMC. I am really proud that he is going to chair this function. Welcome, sir, Dr. Kulandeswamy, sir. Thank you, sir. Thank you for accepting our invitation. Thank you, sir.
Thank you.
Sir, now I request Kulandeswamy, sir, to introduce our speaker and proceed the sessions. Please.
Okay, thank you. Thank you very much. So good evening to the immediate past president of Tamil Nadu IMA, Dr. Abul Hassan, and the Dr. Sengutuvan, the current president of IMA, Dr. Karthik Prabhu, the secretary, and the IMA president-elect, Dr. Sridhar, Dr. Ashraf, the chairman of the academic committee, then Dr. Arul Raj, the coordinator for the academic committee, and all the participants. Good evening to all of you. Actually, there are two aspects. So one is first of all, the tireless efforts of the IMA in conducting this kind of programs throughout the year, particularly, and the important courses. Even in one course, the IMA is for the past 4 or 5 years, I think 5 years, conducted in infectious diseases course. So for that, Dr. Neminathan is the coordinator. As he said, Dr. Neminathan doesn't require any introduction. Actually, in fact, so we have started working with him during the infectious diseases outbreaks, particularly during the dengue. So I wonder many times. So he is a very busy pediatric practitioner in a child trust hospital, which he founded. So he somehow, he is an example that if you have a vision and mission in your life, so you will definitely find time. He is an example. Every day we are meeting many people. So I have no time. I think Neminathan is the most busiest person, but still he finds finds time to any number of sessions. I think every month, I think he is spending almost about 30-40 hours in a month for doing this CME kind of programs, in addition to teaching his students and DepNB students in his own hospital. So in fact, he had organized a program with the author of the WHO book, madam from Malaysia. So what is her name?
Dr. Lucy Long. Dr.
Lucy Lam. So, and I think Lucy Lam will be addressing a session for this batch of students also, I hope. So, with this introduction, so and the topics, today's topic selected is a very, very important topic. That is the antibiotics and day-to-day practice, do's and don'ts. It is very, very important. And so many times, so to share a small experience. So during the diphtheria outbreak in Kerala, then subsequently during the diphtheria outbreak in certain areas in Erode district and Coimbatore district, so many of the people have, even our own people have forgotten about penicillin. And the penicillin was also not available in many of the stores because it is a price controlled drug. The people are not the pharmacy people. They are not very much interested in storing, in stocking, and selling the medicines. So finally, we found that there are some people in Cochin and some people manufacturers in Bengaluru. They're able to, but the problem with manufacturing penicillin, it's not like chemicals. We can just pick it up the raw material and make it into capsule or tablet form and distribute. It takes it takes about 3 weeks for the batch to be produced. So this is the situation. So we need to know about not only about the uses, the do's and don'ts, and also what are the uses of different antibiotics, how they act, what is the minimum inhibition concentration, so and what is the drug resistance, particularly the multi-drug resistance, including TB and diseases like malaria. So these are all the knowledge, the basic knowledge for all practicing doctors in microbiology and pharmacology is very much essential for day-to-day practice. With the small introduction and background, so now I request Dr. Neminathan, the eminent pediatrician, EDD's undergraduate and postgraduate, both from Madurai Medical College. I request Dr. Neminathan to start his session. Thank you.
Thank you very much, sir, for your introduction. My sincere thanks to Dr. Sengutuvan sir, Dr. Karthik Prabhu, Dr. Abul Hassan sir, Dr. Sridhar, Dr. Asaf sir for inviting me to give a talk on academic forum, and my friend Arul Jodi for crowd pulling nearly 1,000 doctors for this meeting. And my sincere thanks to Dr. Gauri Shankar and my guru, Dr. Kulandeswamy sir, which I've been working with him for nearly more than 20 years when he was from the Director of Public Health, doing lots of activities during the COVID time, flu time, and also dengue time. Now he is one of the inspiration to me. So thank you. With that introduction, today I'm going to talk to you about a very, very important topic, CME on antibiotics, do's and don'ts for the practitioners. Friends, this CME is going to be a clinical case-based interactive seminar with an educational objective to provide simple and practical management strategies to practitioners working in areas with limited resources, with evidence-based answers to prescription of antibiotics. And there is no conflict of interest, and this will be of highest standard in CMEs. Friends, with this introduction, let me jump into the topic of today's. Friends, you will all agree with me, fever is a friend. It is a controlled rise of temperature regulated by thermosensitive cells in hypothalamus. It is not a disease per se, it is a manifestation of an underlying disease. So do not treat a fever, always treat the cause of fever. Friends, whenever you see any child in your OPD, you have to make an empirical diagnosis. Empirical diagnosis consists of 4 components. One is anatomical component, second is etiological, third is a pathological, and fourth is functional. After making an empirical diagnosis, you have to make sure whether it is a simple viral fever or a bacterial illness. If it is a viral fever, you need to prescribe antibiotic. If it is not, do not prescribe antibiotic. So how in a matter of few seconds to arrive at that diagnosis whether the cause of fever is viral or bacterial. You start applying this 5-point rule for every child who comes to your OPD. You will be correct 99.9% of the time without doing any lab test, just by applying what you have studied in your undergraduate curriculum. Point number 1, any sudden onset of high-grade fever in a previously healthy child swings the pendulum to an organism that has got ultra-short incubation period. They are viruses. Bacteria have got long incubation period. Any more than one member in the family having fever at the same time means ultra-short incubation period. In a given family, more than 2 members, 3 members, within the city, within the state, within the country, we have seen lots of pandemics, swine flu pandemic, COVID pandemic, all are due to viruses. If there is a more number of cases, particularly during this season, now everybody is saying season is busy. The 99% of the season is created by the viruses. So, any dissemination of signs and symptoms, if many sites are involved, if you throw a torchlight and see the eye is red, throat is congested, nose is watery, and the child has got cough, diarrhea, and skin rash, indicating that the RS, respiratory system, abdomen, and skin is involved. Dissemination is hallmark of virus. Multiple system involvement is virus. Whereas in bacteria, you got bacterial pneumonia, only one system. Bacterial dysentery, only one system. Bacterial UTI, only one system. Bacterial lymphadenitis, only one system. So localization is hallmark of bacteria. Dissemination is hallmark of viruses. And if you ask the mother, Yenama Pandada, what happened? She will immediately have a verbal diarrhea. My child has got cough, cold, watery nose, red eyes, throat pain, joint pain, vomiting, loss of appetite, skin rash. If there is a verbal diarrhea, probably it is viral. You ask the mother how the child behaved between 2 fevers. That is called interfebrile period. If the child is up and about during the 2 febrile episodes, that's called interfebrile period. Probably it is viral. By applying this simple 5-point rule in every case of fever that comes to your clinic, within a matter of minutes, you can make a diagnosis as short pyrexia, nil localizing, probably viral, without danger signs, and you need not write antibiotics. This is a very, very first and simple message that you have to start in your practice. By applying this 5-point rule in your practice, you can bring down the prescription of antibiotics by more than 90%. So vast majority of the fever cases in your day-to-day practice, particularly during monsoon time or viral nature, your antibiotic prescription will come down statistically significantly by applying this simple 5-point rule. I'm sure all of you take a snap of this picture slide, and at the end of the meeting, I'll show you my number. You can send a request to me. I'll send you all the slides for your reading when you're free. So let me start with cases. Instead of building a theory, let me start with some interesting cases that we see in your day-to-day practice. Here you have a 3-month-old infant, comes with 5th day of fever. The father is a lab technician who has done a CBC in his lab. Total count is 22,000. Child has got polys of 90%. And by looking at this 3-month-old child with 5 days of fever, high-grade fever, more than 1 or 2, polymorphic leukocytosis, what 3 things will run in your mind? That is, how will you make an empirical diagnosis? And what will be your next line of investigations? So these 4 are the options. Friends, I'm sure many pediatricians are there in this meeting. I could see many pediatricians in this meeting. I'm sure all of you will make an empirical diagnosis of 3 conditions. One is occult pneumonia, second is occult UTI, third is occult bacteremia. Any child who is around 3 months of age with polymorphic leukocytosis, temperature more than 102, please make a diagnosis and investigate for 3 conditions. One is do urine microscopy to rule out urinary tract infection. If pustules are more than 10 in uncentrifuged urine, take urine culture shot on antibiotic. Then if urine is normal, if the child has got tachypnea, dyspnea, or grunting, you take an X-ray chest, or both are normal, you can take a blood culture and start antibiotic. Please remember, do not start antibiotic without taking culture. That's an important carry-on message. Any child with polymorphic leukocytosis between 3 months to 3 years, think of occult pneumonia, occult UTI, occult bacteremia. So I'm sure you will agree with me. As per IDSA, 41% of children between 3 months to 36 months with polymorphic leukocytosis, even without evidence of pneumonia, will show evidence of pneumonia and radiological finding. Please take an X-ray chest. That's very, very important. Otherwise, you will miss a pneumonia. This is another child whom we see frequently during this monsoon. The mother will come with a sore throat, difficulty in swallowing. On seeing the throat, you can see the follicles on both tonsils. This is called acute follicular tonsillitis. It is caused by group A beta hemolytic streptococcus. So the question is, whenever you see a child like this, then the next question is, should I start on medicines, particularly which among the four? Sometimes medical representatives come and tell you that there is a new drug called ferropinum, which can be given to all children with respiratory infection. Please start prescribing. So do not get carried away by false claims. Please remember, this organism, group A beta hemolytic streptococcus, is an organism that has not developed resistance to penicillin since the invention of penicillin. Another organism is spirochetes. So the treatment of choice in such a child with acute follicular tonsillitis is amoxicillin, given at the dose of 40 mg per kg per day, 3 divided doses for a period of 10 days. This is given to prevent rheumatic heart disease. Please remember, it has to be given for 10 days. Never prescribe azithromycin because there is nearly 22% resistance of this organism to azithromycin. The ferropinum, which I told you earlier, is, if you look at it, it is, if you want to call it, you have to call it as unferropinum. It's not a ferropinum, it's an unfair pinum. It is a reserved drug. Do not use it in your day-to-day practice. Sometimes you do see the lab report coming as group A beta hemolytic streptococci resistant to amoxicillin. In that case, do not change the antibiotic. Please change the lab. So here you have another child, a 11-month-old infant who was healthy, all right, developed cough, cold, fever, high-grade fever more than 1 or 2 or 4 days duration. On 4th day, the mother complained that he became fussy, wakes up in the middle of the night crying. So I'm sure many of you guess a child who started as upper respiratory infection, now developing fussy and waking up in the crying. First thing, as a pediatrician, what we do apart from stethoscope is to use an otoscope. The moment you see the drum, you can see the classical findings of acute otitis media, loss of cone of light, bulging. So you make a diagnosis of acute otitis media. So the first thing that you must ask is whether to use antibiotics or not. This is a simple carry-home message for all doctors in OPD practice who sees acute otitis media. Please remember, in any child less than 6 months of age, if they have got acute otitis media, whether it's a mild, unilateral, bilateral, severe, with autouria or without autouria, start on antibiotics. That's very, very important. And children between 6 months to 2 years of age, if it is a severe acute otitis media, whether it is unilateral or bilateral, definitely you need to start on antibiotics. Whereas if it is a bilateral otitis media without autouria, you are supposed to start antibiotics in this age group. Whereas in unilateral acute otitis media, you can wait and watch. Many times you can have viruses that comes with the acute otitis media unilateral without autouria. You can wait for 48 hours. If symptoms subside, you need not start on antibiotic. Many times it will settle down with decongestion and paracetamol. If after 48 hours, if symptoms persist, you need to start on antibiotics. For children more than 2 years, most of the time, whether it is bilateral otitis media or a unilateral otitis media, that is simple in nature, do not require antibiotics upfront. You have to wait and watch. Only if the condition is severe, if there is a severe autoalgia or autoalgia more than 48 hours, or a fever more than 102, that's called severe otitis, acute otitis media. Only in that condition, you need to use antibiotics in children more than 2 years. Otherwise, do not use antibiotics. And on the contrary, if there is an autoria, if it is due to acute otitis media, then you need to start on antibiotics irrespective of severity or irrespective of age. Now we decided whom to start antibiotic, when to start antibiotic, under which age we have to give antibiotics. Let's go what antibiotic to give. Friends, when you look at this child, you must look at host factors. The age is 11 months. Risk of serious bacterial infection is high. The severity is high. This is a vaccinated child. Most of the time, acute otitis media in this age group is caused by Streptococcus pneumonia or non-typable H. influenza or Moraxella catarrhalis. The antibiotic of choice, as I told you earlier, is amoxicillin, because penicillin resistant among non-meningeal isolates of pneumococci is extremely low in our country. So amoxicillin is the drug of choice. Sometimes in vitro it may be resistant, but in vivo it will be sensitive. So it is amoxicillin is the drug of choice. It is a narrow spectrum antibiotic. It is inexpensive, well tolerated, time tested. So always whenever you prescribe antibiotic, you have to apply this rule. So having chosen amoxicillin, the dose is around 40 to 50 milligram per kg per day. It has to be given for 10 days. And please remember, whenever you choose amoxicillin, you have to consider two conditions in mind. One is the child should not have received any antibiotic, penicillin or cephalosporin antibiotics for any illness in the past 30 days, number one. And second thing is child should not have concurrent purulent conjunctivitis, because organisms can be ESBL producing organisms. So in that case, you have to give amoxiclav. So let's see what are the conditions you will give amoxiclav. If the child has received any beta-lactam antibiotics like penicillin, ampicillin, amoxicillin or cephalosporin in the last 30 days, you have to start on amoxiclav. There is a concurrent purulent conjunctivitis suggestive of ESBL organism or beta-lactam producing organism. You need to give amoxiclav. Or when there is a history of recurrent otitis media non-responding to amoxicillin, you need to give amoxiclav. In amoxiclav, you got two sets of amoxiclav. One is amoxicillin to clavulanic acid ratio 7:1. That is the ideal one that has to be started with the dose of 50 milligram per kg per day. Sometimes, rarely, we recommend amoxiclav that is 14:1, that is double strength or extra ES. That is recommended only in communities where there is increased prevalence of penicillin non-susceptible Streptococcus pneumonia. In our country, particularly in Tamil Nadu, it is not there. In Kerala, we have started receiving nearly around 11%. But fortunately, in all over India, Streptococcus pneumonia has not developed resistance against penicillin. So this 14:1 ratio is not needed as per up to date. Okay. So what is new? Previously, we used to give 10 days course for a child between older child, more than 2 years of age. So now it is recommended if there is a perforated tympanic membrane or a recurrent otitis media in a child between 6 months to 23 months, give 10 days course. Otherwise, you can reduce to 5 to 7 days if the child is more than 2 years with uncomplicated AOM. This is recommended by the Committee of Pediatrics, Committee of Canadian Pediatric Society, and also up to date. So nowadays, we are started reducing the course of antibiotics in many illnesses like pneumonia, otitis media, UTI. So this is another situation where general practitioners quite often see in pediatrics. A child, school-going child comes in the evening after school with being bitten by a child coming to you for antibiotic. So first thing you must know is any bite here in such a child is always polymicrobial. Do not prescribe ciprofloxacin, metronidazole or ampicillin. The drug of choice is amoxiclav. If you look at pediatric textbook of infectious disease, Fien and Cherry, there are nearly 47 organisms in the mouth of a young child. So it contains aerobes, anaerobes, it contains bacterioids, gram-positive organisms, gram-negative, multiple organisms. The commonest is Echinola cordens. So the best antibiotics is co-amoxiclav. So by looking at this child who came for a fever of 15 days duration, we made a diagnosis of scrub typhus. I'm sure all of you will agree with me. This is a bite by a sugar thrombocolid mite, and this condition is called Escher. In scrub typhus, always you have to remember many conditions. I'm sure that there are no vaccines for scrub typhus. It can even cause encephalitis. Escher is not compulsory in scrub typhus because only 7 to 70% various studies have got Escher. Nearly 30% can have scrub typhus without Escher. The most important thing, what we all believe was doxy should not be given for children below 8 years. The recent recommendation by FDA is that, and the American Academy of Pediatrics is that it can be given even to neonate below 8 years. But that should be evidence, that should be scientific backing. You should not give it beyond more than 7 days, because it will cause cosmetically perceptible staining of the teeth if it's given more than 7 days. So I see lots of students joining this meeting. So you have children coming to you with fever, with rash. So the fever rash appears on day 1, it is varicella, scarlet fever day 2, smallpox day 3, measles day 4, typhus day 5, dengue day 6, typhoid day 7. The mnemonic is that very sick patients must take double tablets. You can get the slides at the end of the meeting by sending me a message in my personal number. Sometimes we do see children coming to us with conjunctivitis in our OPD. Sometimes if you ask them, the child will tell that I got irritation in the eye. Child keeps on rubbing. On examination, you find a preauricular adenitis. So please remember, whenever you see a child with conjunctivitis, lower respiratory tract infection, cough and cold, watery diarrhea, skin rash, and urine shows puzzles more than 10. And if you do counts is higher with the CRP higher, probably you have to think of adenovirus that comes in crops. Couple of months back, we had lots of adenoviral outbreaks. This does not require antibiotic. So the message is, whenever you see a child with conjunctivitis, do not prescribe topical antibiotics. That is an area where we misuse antibiotics. So how to choose whether it is bacterial or not? So when there is a purulent discharge from the eye and there is a redness in the eye without itching or without preauricular adenitis, it is bacterial conjunctivitis. You are justified in prescribing antibiotics. Vast majority of our conjunctivitis, they have gritty feeling, and on examination you can see a preauricular lymphadenopathy. It is viral in nature. No role for oral antibiotics or topical antibiotics. Please remember that. Always, whenever you see a child with conjunctivitis, ask the history. Does the child have itching, or is the child rubbing the eyes continuously? Or put your hand in front of the ear, see for preauricular lymphadenopathy. If it is there, do not prescribe antibiotics, either oral or topical. Even topical causes lots of antibiotic resistance. So sometimes we see children coming to you with an injury, thorn prick or a needle prick, coming to you with swelling, and on X-ray you find an osteomyelitis. So whenever there is a penetrating injury in a child and there is an osteomyelitis following that, more than 90% is due to Pseudomonas, and nearly 1.5% of children with penetrating injuries develop osteomyelitis. Though it is rare, but you have to keep Pseudomonas the back of the mind. I'm sure you will all agree with me, there is no oral anti-Pseudomonas drug. It has to be treated with drugs like piperacillin tazobactam. So whenever there is a child with osteomyelitis, ask for penetrating injury and keep Pseudomonas in the back of the mind. So many a times in our busy OPD, we see children coming to you with cutaneous abscesses, abscess here and there. This is a child who has got a small abscess above the cubital fossa on the left forearm. So whenever you see that abscess, you have to take a tape and measure the size of the abscess. Please remember, whenever you see a cutaneous abscess, The message is, if it is less than 5 centimeters, do only IND. Do not give antibiotics. This is a recommendation by Infectious Disease Society of America, IDSA recommendation. Any child with cutaneous abscess which is less than 5 centimeters, do only IND, do daily dressing, it will heal off by itself. Antibiotics are indicated in abscesses when it is more than 5 centimeters, or when it is a severe or extensive disease, or when it is progressing to cellulitis, or whenever the child has got systemic illness like toxicity, or when there is comorbidity, immunocompromised child, or the abscess is at difficult sites, difficult to drain, such as danger areas of face or genitalia, you have to give antibiotics. Only these 5 conditions. Do not start unnecessary antibiotic in a child with cutaneous abscess less than 5 centimeters. Do only IND, do cleaning and dressing. So here you have a 9-year-old child who comes to you with fever, vomiting, abdominal pain of 6 days duration. Mother says child has got decreased food intake, no other localizing signs, hemodynamically stable. On examination of the child on the couch, you see a moderate hepatomegaly. So you order for an investigation because day 6 fever. The child comes back with leukopenia, 3,210 cells, with monocytopenia. Monocytes are 0. Hemoglobin is normal, hematocrit is normal, platelet count is normal. There is a moderate rise in SGOT-PT. When you have such a finding, this child, we ask the own history. Did the child travel? Yes, the child traveled to Mumbai. What did the child eat there? Child took pani puri. After that, child developed watery diarrhea, abdominal pain, and all these symptoms. So instead of travel to Mumbai, taking a pani puri, having leukopenia, having eosinopenia, with hepatomegaly, swings the pendulum towards enteric fever. We drew blood culture and started the child on antibiotic. Since the child was toxic, not tolerating food, we admitted the child started on ceftriaxone. The blood culture grew Salmonella typhi. So our diagnosis was confirmed. So whenever you see a child with symptoms, GI symptoms, history of travel, history of taking unhygienic food, history of vomiting, diarrhea, abdominal pain, coated tongue, hepatomegaly, relative bradycardia, in CBC, eosinopenia, first your diagnosis should be Salmonella until proven otherwise. Take culture and start antibiotic. If the child is not sick, start on cefixime at 20 mg per kg weight. If the child is sick, start on ceftriaxone at 75 mg per kg weight. Please remember, as per the antibiotic susceptibility profile in Indian Journal of Infectious Disease, IDSA, many of the past antibiotics, sorry, it is not visible. The one on the red shaded area is ciprofloxacin, almost 100% resistant to both Salmonella typhi, Salmonella paratyphi. Never prescribe quinolones in typhoid. Our olden drugs like ampicillin, chloramphenicol, cotrimoxazole, trimethoprim, sulfamethoxazole, almost 100% sensitive. We are regaining back. And newer drugs like ceftriaxone, azithromycin, and cefixime, 100% sensitive for both Salmonella typhi and paratyphi. The message here is never start a quinoline for a child with enteric fever and avoid doing Vidal. Infectious disease secret when you do CBC is that C for eosinopenia. In a Coulter cell count, it will not be eosinophils, it will be monocytes. M. If you see M as 0 or 1 or 2, it is an enteric fever clue. Always take blood culture, which is a gold standard. For an older child, you have to take 10 ml. For an adult, you need to take 20 ml. The blood to broth ratio should be 1:5. Then only culture will be growing. If you take 1 or 2 ml, culture will be negative in spite of enteric fever in the child. If you are treating outpatient, dose of cefixime is 20 mg per kg per day, 2 divided doses. You have to give it for 3 to 5 days after the effervescence of fever, then stop. The same as ceftriaxone, same duration. Azithromycin is a drug 20 milligram per kg per day is given as OD for a period of 5 to 7 days. Please remember azithromycin has got post-antibiotic effect because of deposition in Golgi apparatus. The chance of recrudescence is less when you use azithromycin. Always use monotherapy. Do not give cefixime with azithromycin or ceftriaxone with azithromycin. Please remember, even after starting appropriate antibiotic, the fever will persist for 4 to 6 days after starting antibiotic in enteric fever. Do not change antibiotic on 3rd day or 4th day. You have to wait for minimum of 6 days. So this is another child, 6 years old school-going child, presented with 8 days of fever. On 3rd day, the child came to you with pain on the chest on the left side. On auscultation, you found basal crepitation, a suspected bronchial breath sound. Child was febrile, fever 102. Child was tachypneic and also dyspneic. There was a mild grunt. Child had a classical maculopapular rash and also redness of the eye. The mother came running at 11 o'clock to our hospital because of blurring of vision. When CBC was done, this child showed hemoglobin was 7. The same child 3 months back, hemoglobin was 40. This is a new anemia that's developed after this illness. The reti count was increased. So the total count, once again, polymorphic leukocytosis. Blood culture was done. It was sterile. Child was started on ceftriaxone. Even after 3 days of 6 doses of ceftriaxone, child did not respond. X-ray chest was done that showed a left lower lobe pneumonia. So what could be the reason, even after starting ceftriaxone, the child did not respond? Is that this is a mycoplasma pneumonia. As you are all aware, ceftriaxone acts on organism that has got cell wall. This organism does not have cell wall. So you have to use azithromycin or doxycycline. Okay. So the clinical clue is that if the child comes to you with an anemia, recent onset anemia with increased reti count, or the child comes to you with maculopapular rash or mucositis or eye involvement with conjunctivitis, sometimes blurring of vision with multistem involvement, you have to consider mycoplasma, which is very common in school-going children, and start the child on azithromycin or doxycycline. So, friends, we have seen lots of children with antibiotics misuse. Same way, we had lots of issues with cough syrups. So, there are 4 important carrier messages for all doctors. Many times, fever and cough come together. If you have a child with cough, do not do unnecessary CBC or X-ray chest. Most of them you can diagnose clinically. X-ray chest should not be done for a cough. And cough syrups are not indicated for children below 2 years. When the child is above 1 year, you can give honey because it is a safe demulcent without side effects. It can be given at the dose of 2.5 ml to 5 ml with lukewarm water twice or thrice a day for any child above 1 year. It should not be given for children less than 1 year because of the fear of botulism. Whenever you prescribe cough syrup, always use single ingredient cough syrup. If you auscultate a wheeze, give only salbutamol or levosalbutamol. If there is a dry cough in a child who has undergone a surgery for hernia or any other surgery, you have to give a centrally acting cough suppressant dextromethorphan single ingredient. If you are giving a child for a cough with postnasal drip, you can give 2nd generation antihistamine like desloratadine or fexofenadine or levocetirizine. Always single ingredient. There are many cough syrup that contains antihistamine, decongestant, mucolytic, cough suppressant, bronchodilator, all 5 having opposite action put in a single bottle, nothing will act. Never go for polypharmacy. Always use monopharmacy. And please remember, you have to avoid chlorpheniramine maleate and phenylephrine combination in all children below 4 years. That is not recommended by the Government of India. So these are very, very important carrier messages for any child who comes to you with cough. So CBC is a quite useful test in your day-to-day practice. So when you do CBC in a child, as I told you earlier, in dengue, you can have a hematocrit that's rising. And also sometimes you can have leukopenia with thrombocytopenia. So high hematocrit is always you have to consider dengue. In malaria, you can have eosinophilia. Normal eosinophil count is around 6 to 9. In malaria, you can have 15 or 21, or with the low hemoglobin. Then you have to consider malaria. When there is a eosinopenia, you have to consider enteric fever. CBC is a quite useful tool in making a diagnosis. Just by looking at CBC, you can make a diagnosis. And I'm coming to the last slide. Supradiaphragmatic infection or caused by gram-positive organism. The only drug you are supposed to use is amoxicillin. In infradiaphragmatic infection caused by gram-negative organisms, the only drug you are supposed to use is cefixime. If the child has got bacterial dysentery, the dose of cefixime is 8 to 10 milligram per kg weight BD. If the child has got urinary tract infection, the dose of cefixime is 15 milligram per kg weight per day BD, because you need to achieve a higher concentration urinary system. And if you have got enteric fever, the dose of cefixime is 20 milligram per kg weight. In skin and soft tissue, you have to use first generation cephalosporin, either cephalexin or cephaloxin. Only 3 antibiotics in pediatric practice. So let me come to the carry home messages. From today, develop the culture of culturing. Never start antibiotic inpatient without doing culture. Even in outpatient, if you suspect organisms like UTI or enteric fever, take culture and start antibiotics. And always arrive at an empirical diagnosis and put it black and white in the case sheet in your OP ticket that this is viral fever. You must have guts not to start an antibiotic in viral fever. Do not say, I'm starting empirical antibiotics. Antibiotics are required in viral fevers only in 3 conditions. Number 1, there is a sudden deterioration in the general condition of a child with viral fever. You are justified in starting antibiotic. Number 2, if the illness is prolonged. Suppose there is usually in flu, the fever stops by 2nd day, 3rd day, or 4th day. The fever persists beyond the normal course. There is a bacterial superadded infection, you can start antibiotic. Or when there is a recrudescence, that is fever disappeared, child was all right for 3 days after viral fever, child developed fever with symptoms, probably secondary bacterial. Only 3 conditions you are allowed to start empirical antibiotic in a child with viral fever. 99.9% of the children do not have this situation. So as a rule of thumb in practice, when you write viral fever, do not write antibiotics. If at all you use antibiotic, use only 3 antibiotics. And as far as possible, use only oral antibiotics like ampicillin or amoxicillin or cefixime. As far as possible, use narrow spectrum antibiotics. Do not use broad spectrum antibiotics like ferropinum, which is a reserved drug. As far as possible, confine to a shorter course. Do not give a prolonged course because it will by itself cause antibiotic resistance. Nowadays, we have started reducing the course of antibiotics in pneumonia 5 to 7 days, in UTI 5 to 7 days. Avoid irrational combinations because in the market you've got combination of cefixime with clonalic acid. Many irrational combinations like norfloxacin with metronidazole, ofloxacin with ornidazole. Never use them. If you use ofloxacin with ornidazole for a child with bacterial enteritis, you'll be correct 3% of the time, you will be wrong 97% of the time because parasitic enteritis in children is only 3%. Never give combo drugs. Not only antibiotics, not only these anti-diarrheal drugs, in polypharmacy in cough syrup and also fever medicines like ibuprofen with paracetamol, mefenamic acid with paracetamol. In viral fevers, use only paracetamol. All your NSAIDs, mefenamic acid has got antiplatelet action. Try to use only paracetamol. Do not prescribe 2 antibiotics. If the fever is more than 1 or 2, give mefenamic acid. If the fever is 1 or 2, give ibuprofen. If the fever is 100, you give paracetamol. Always prescribe only 1 antibiotic, paracetamol. And always I request all of you to practice these 4 Ds in antibiotics. That is correct drug. You have to choose the correct drug. Do not use cefixime for upper respiratory tract infection. Correct dose. You should not use underdose or overdose. Correct duration. Duration is very, very important. Many times, sometimes you tend to prescribe for 1 day or 2 days. Never do that. You have to, if you make a definite diagnosis of infection, for example, bacterial tonsillopharyngitis, give it for 10 days. If you diagnose a bacterial suppurative adenitis, give it for 7 days. If you make a diagnosis of bacterial dysentery, give it for 5 to 7 days. Do not give short duration or a prolonged duration. Duration has to be correct. And the last D is de-escalation. Sometimes you think that it is bacterial after drawing blood culture, after seeing counts that is slightly high, or after seeing CRP that is slightly high, you start on antibiotic. The nurse will come and tell, before I gave the injection, IV, any drugs like ceftriaxone, after a single dose, the moment I withdrew the syringe, fever settled. Fever did not appear. No bacterial illness will settle down with a single dose of antibiotic. If it settles down with single dose of antibiotic, probably your empirical diagnosis is wrong. You must have the guts to stop antibiotic. That's called de-escalation. Please remember, whenever you admit a child with fever, do not start on ceftriaxone. Please remember, fever is not ceftriaxone deficiency. And never continue antibiotics just because you have started. If the fever disappears immediately, most probably it is viral. Stop antibiotics. You have to practice this de-escalation. And please remember, do not rely upon the CBC, CRP. Sometimes CBC total count may be high, CRP may be high, even in viral illnesses. You have to monitor them closely. You look for danger signs. You see for deterioration. If the child is improving well, do not start antibiotics. Just with IV fluids or just with ORS, paracetamol, you can monitor. But only thing is you have to educate them about danger signs. I'm sure all of you know about danger signs, which I told you in the earlier part of my speech in IMA. So if there are any danger signs, they should come back. Whatever the illness is, you have to tell them that, look, if the child has got reduced urination or excessive irritability or drowsiness, or the child has got loss of appetite or persistent vomiting, or the child has got new symptoms like abdominal pain or any bleeding anywhere, or the child has got tachypnea or dyspnea or breathing difficulty or feeding difficulty, or the child has got cold peripheries, they have to come back. If you tell them about these danger signs, you can reduce the mortality to fever to 0. So our aim of this continuing medical education by IMA and other organizations like IAP is to reduce the mortality following these viral illnesses to 0. So with this, I once again thank the organizers with this last message. Most important message is all fevers are not infectious. Number 1, all infections are not bacterial. And please remember, antibiotics are not antipyretics. This is a very, very important message. All fevers are not infectious. All infections are not bacterial. Antibiotics are not antipyretics. With this introduction, let me come to the thanking part. I once again like to thank IMA, Academic Affairs, Dr. Ashraf sir and Dr. Arul Jyoti for inviting me, and Dr. Kulandeswamy sir for being a moderator. Friends, if you want my slides, you can contact this number 98422 11179. You can send a message to me. I'll send you the slides. I'll hand over the slides to Dr. Ashraf sir so that it will come out in a book form so that you can read. It can be kept on your tabletop. You can read whenever you have time during your busy practice. Once again, thanking IMA, all the leaders of IMA, and nearly 1,000 doctors have joined this meeting. My appreciation to Dr. Arul Jyoti for his dynamism. If there are any questions in the chat box, Dr. Arul Jyoti, you can start one by one.
Moderator sir, sir will start.
Yes, actually, let me share. So one question is about the minimum inhibitory concentration for
Yeah.
antibiotics.
Please, whenever you see a culture report, you have to see MIC. MIC is the minimum inhibitory concentration that is required for the antibiotic to curtail the growth of the organism. So less the minimum MIC, better the antibiotic. Sometimes if you have 3 drugs like ceftriaxone or piperacillin tazobactam, if one has got 0.25, another has got 4, another has got 8, you have to choose the one with 0.5. But most important thing is you have to see whether this drug is resistant or sensitive. Sometimes even with the low MIC, if the drug is resistant, do not use that. If it is sensitive, you have to use that. Sometimes there may be some drugs in CSF. You can see piperacillin tazobactam has good MIC, but this drug will not penetrate inflamed meninges. So do not use piperacillin tazobactam even with low MIC. So you have to know for urinary concentration, you have to use drugs like nitrofurantoin, which has got a good urinary excretion, cotrimoxone. You have to use them. So MIC, you have to use it with caution, but preferably use when the MIC is low in a sensitive drug. That's very, you have to look at the break point.
Yes, as I have already mentioned, we must have all the practicing doctors from MBBS doctors to specialists. We must have a very sound knowledge in microbiology and pharmacology. That is very, very essential. So then another important question, it's a very, very important question. That is about the antibiotics which we used long back. But many of the antibiotics presently it is not even prescribed. For example, the penicillin, tetracycline, chloramphenicol, and sulfonamides. So Dr. Neminathan can.
Yeah, these
give a
antibiotics are coming to our, once again to our, this slide is not visible. You can see in this slide, most of the antibiotics we are not prescribing. Now the Salmonella typhi has become susceptible to that. If you look at paratyphi, ampicillin 100% are susceptible. Chloramphenicol 100% susceptible. Cotrimoxone 100% susceptible. Previously, we have stopped using that. Now it has become sensitive. So whenever you see a child with typhoid, Salmonella typhi or paratyphi, you can safely use cotrimoxone. It's re-emerging. And please remember, never use quinolones in pediatric practice, not only in enteric fever, in UTA also do not use quinolones. That's very, very important. Resistance is very high.
I think to add to Dr. Neminathan's points, see the most of the drugs which are the price controlled drugs. Price controlled drugs means there is very cheap. Even the 8 lakhs or 10 lakhs units of penicillin, which costs about 10 rupees or 15 rupees depending on the manufacturer. So the market is not making profit because of the old drugs, which are the sulfa group of drugs, the cotrimoxone group of drugs, then even the chloramphenicol, tetracycline. So, these drugs are penicillin. These are all. It is become very, very difficult to make sure that these drugs are available in the market so that we can prescribe. So still the Child Survival and Safe Motherhood Program, the cotrimoxone is recommended, and the village health nurses and other people are trained. And during the lepto outbreak in Kerala floods, the people are frantically searching for the doxycycline and penicillin group of antibiotics. That is very important. And similarly, the Vibrio cholera, so now the cases are reported in some of the hill areas recently in Tamil Nadu, including Tamil Nadu. So the people are using the doxycycline. Then again, the tetracycline, again, it's a very valuable drug. The doxycycline when it comes to the hard bacteria, that is very difficult to penetrate the bacterial cell wall and to act against it, particularly the indeterminate group of organisms. So then again, the role of doxycycline is indispensable. So in sexually transmitted diseases, again, the tetracycline plays a role. And some of the drug-resistant malaria, then again the sulfa group of combination, the drugs are still used. And again, it is also used in some of the chronic conditions to prevent infections. So the drugs which we are earlier used 3-4 decades back, still they have its value, but how judiciously and for what condition we use is very important. It was really a surprising. Many of our practicing doctors, they do not even remember the 3 category of penicillins: benzyl penicillin, procaine penicillin, and benzathine penicillin. Benzathine penicillin, because of this rheumatic fever, still a few cases are present and few children are receiving the monthly dose of benzathine penicillin. Most people are aware of benzathine penicillin and it is available in the market also. But still we find it very difficult to make sure that procaine penicillin and the benzyl penicillin is available in the market. So this is a very, very important question. The next I have seen another question. What is the drug, what should be done, or what is the drug we should give for a running nose of children below 3 years of age? One other question I have seen in the chat box.
If there is a running nose, do not treat. Most of the time, running nose does not require treatment. Allow the nose to run, it will settle by itself. If you treat a running nose viral URI, it will take 7 days. If you don't treat, it will last for a week. So ultimately, it is the same. Do not treat the child. Do not drug the child. Allow it to run. Because many times, common cold is caused by many viruses like rhinovirus, other viruses. They are in the community in which the child keeps on having a running nose, sometimes light cough, mild fever. It will settle down, and after a couple of days, child will develop another cold. So they are called common cold, in which the fever will not be common. There'll be no cough, there'll be no body pain, body ache. Child be having sneezing, running nose, all those things. So in those conditions, you just allow the child to get cured by itself. Nature will cure. Don't give any medicines. So it's safe to avoid. It's called non-pharmacological treatment. Do not give any drugs. So there was another question in the chat box asking about in impetigo should we give oral antibiotics? Please remember, in impetigo, just cleaning and then application of mupirocin ointment is sufficient. No need for antibiotics or systemic antibiotics. As I told you, the child is toxic. If the impetigo is in danger area, tip of the nose, because of the connectivity to great vein of Callan, you have to give antibiotics. Otherwise, a simple impetigo in a non-toxic child just requires cleaning and topical application with mupirocin is sufficient. So only thing is, it is contagious. It will spread to other children. You have to keep the child till it settles down. Ask the child not to go to school, because impetigo is called impetigo contagium, from one side to other side, from one child to another child. That's very, very important. If you want slides, please don't post it in the chat box. Please send it to my personal number. Then only I will send the slides. Send it to my WhatsApp to personal number 98422 1179. So then only I'll be able to send you my
Slides.
my slides. So please note down this number. So you have to send the request to my personal number. Then I'll send you the slides. So please don't post it in the group.
And another important question, that is, does all injectable antibiotics require the routine test dose?
Does all antibiotics require?
test dose
Yes,
before administration.
many a times cephalosporins or penicillins require a test dose. Your amikacin, gentamicin do not require a test dose. Penicillin group of drugs definitely need a test dose.
I suggest one very simple procedure for a step for all the doctors. Whenever you are, whatever the drug you are using, particularly injections, particularly the drugs which are using in pediatric and the vaccines you are using, you just take out the prescription information which is available in every box and every injection which the manufacturer has given. So usually it will be in font 6 or font 8 size. You will not be able to read it. Kindly now the technology is available. You just scan it whenever you find time. Make sure you thoroughly go through the pharmacological actions, so the contraindications, the adverse events, how to go for the test dose. If you ask how to give a test dose or a penicillin and what dilution it has to be given, then many people, I'm sure that you need to refer your pharmacology book. That is very important. The test dose, how it should be, even for the sometimes for the test dose itself may trigger a reaction. So make sure that you are having in the adrenaline kit. There is an anaphylaxis management kit that is available in every clinic, every hospital, and every emergency, so that you can quickly manage it. Please remember, even the test dose may trigger an allergy. And another question which is there, should we give probiotics routinely with all antibiotics?
No need for probiotics routinely for antibiotics. The message is in your day-to-day practice, particularly in children during monsoon, nearly more than 90% of the children do not require antibiotic. So do not prescribe antibiotic. If at all you prescribe in less than 9% of the cases, do not prescribe probiotics. Routine probiotics are not required for every antibiotics. It will increase the cost of therapy. There is no scientific evidence, level 1 evidence for routine probiotic. So you have to prescribe antibiotics in the correct dose. So if you use it for the correct time, no need for probiotics. So the message is never prescribe antibiotics in a viral fever. That's the message. And that you have to follow, that you have to take as an oath from today. This meeting, only thing I expect from all the 800 plus delegates who attended is that you must take a oath, you must take a self-audit that I will not prescribe antibiotic in viral fevers. I will reduce my prescription of antibiotics from today. That is the best reward you are giving to me.
Yes, true, exactly. Any safe antiviral drug for pediatric age group and geriatric age group, antiviral?
Usually, most of the time, these antivirals had to be used with caution. At present, we got epidemics of flu. In flu, if the child is sick or the adult is sick, if there is a category B symptom or a category C symptom, you can use oseltamivir. In adults, the dose is 75 milligram BD for 5 days. In children, it is 2 to 3 milligram per kg per day, 2 divided doses for 5 days. It is safe, but like antibiotics, even antivirals, if you misuse them, the viruses will develop resistance. So as of now, there's not much of oseltamivir resistance in our country. But when you misuse, you will develop oseltamivir resistant influenza. So never misuse antivirals also. So then we have to, over a period of time, now we are doing antimicrobial awareness program. Then we need to start antiviral awareness program. So never use antivirals left and right. Even in flu, 91% of the flu do not require antiviral. It is less than 9% requires antiviral. If the symptoms are sick or if they got comorbid condition, if there is a danger sign, you need to start oseltamivir, not routinely.
And during the swine flu outbreak, oseltamivir was in Schedule X. So the shops, medical shops, which did not have the Schedule X license, are not able to sell oseltamivir, the syrup or the capsules. So subsequently, the government of India, we changed it to, we moved it away from the Schedule X and to the normally available drugs. So now any pharmacy can sell the oseltamivir syrup or the capsule. So that's for your information. The other question, I think on one of the slide that Naminathan made it very clear, but I don't know why the same question has come again. Common cold, which antihistamine can be given for children under 2 years?
Yeah, if it is a common cold, most of the time they are all, as I told you once again, common cold. And the symptomatology will be very minor and there won't be any fever, there won't be any body pain, myalgia, lethargy, or there won't be any cough. So most of the time it will be running nose, stuffy nose. It's called stuffy nose syndrome. So the only drug that you can use is normal saline nasal inhalation. Normal saline nasal inhalation. That is very safe, no side effects. Another thing that you can do is you can give breast milk frequently to a child with common cold, young child. Breast milk itself acts as like demulcent. It is warm in nature that will give a reduction in the common cold. You can keep the room warm. The warmth of the room itself in winter months, if the room is cold, then there may be stuffy nose and cold, all those things. So you can keep the room warm. So room temperature is inversely proportional to the cough and cold symptoms. So keep the room warm by keeping it humidified with warm water. So that will reduce the need for drugs.